Okay, we'll go ahead and get started. Thank you, everybody, for joining us. Good afternoon to those of you on the East Coast, and good morning still to some of those of you on the West Coast. My name is Nick Hearn from Sync Times. We're really excited about today's webinar. It's the second in a series that we've entitled The Patient Experience. Today, we're going to focus on healthcare analytics, and we've got a terrific group of panelists that have joined us. Just want to go over some of the typical housekeeping items. Everybody is muted that has joined us. We do encourage questions throughout today's session. So if you do have a question, please feel free to use the Q&A or the chat function of the webinar. We'll be happy to address those as we go along, as we're able to field those, but we'll also leave some time at the end of today's webinar to be able to field those questions. Everybody should be able to, or hopefully everyone's able to see my screen. I am sharing a PowerPoint presentation. If anyone's having issues, please feel free to raise your hand within the webinar function. Appreciate everyone taking time to learn a little about us today. Today's webinar is dedicated to healthcare analytics and making decisions to better serve patients by leveraging data. And more specifically, our goal today will be to discuss patient-centered models of care and how leveraging technology and analyzing data is improving patient engagement and outcomes. If you're able to join us for our first webinar in this series, we had an opportunity to speak with practicing PA as well as a medical director, and we really focused on in the clinic setting, what's taking place to focus on the patient and those patient-centered models of care. And today, we're very fortunate to have terrific experts in this space joining us, and that space being that of data analytics. Good morning, Patrick.
Good morning, Nick.
I'm hoping that you could share with everybody today a little bit about your experience in healthcare leadership as your role as a president and CEO of a contracting network.
Sure. Yep. Thanks for including me on your panel today. I've served in community health centers for a little over 20 years in Washington State in a variety of senior leadership positions and within a variety of organizations that are best of their class. Community Clinic Contracting Network is a network of community health centers that share risk for Medicaid lives and also share data through data integration. So we aggregate their data and then we create visualizations for them that help them manage their risk for their populations and also the outcomes of their patients. We've got about 160,000 Medicaid lives in Washington State that are enrolled in those risk contracts.
Terrific. Thank you, Patrick. And I didn't share your last name. That's Patrick Bucknam. We also have joining us today Neil Master. Neil is an experienced MIT researcher, a successful entrepreneur, and the co-founder and CEO of a company focused on care management solutions. So, Neil, thank you for joining us. And if you wouldn't mind just sharing a little bit more about yourself.
Thank you. Thank you, Nick. Appreciate it. Appreciate being on this panel. My career started originally as an AI researcher, and then since then I've been working in the application of those capabilities in healthcare for the last several years. Our focus today at Cohort is really looking at how can we utilize all the available patient information from across all the silos of the EHR, from clinical notes, medications, diagnostics, problem lists, and reconciling and correlating that information, including historical billing, to identify care gaps that otherwise are either unnoticed or are typically inaccessible, particularly at scale. And then we marry that with actual care management services so that we can really do two things: actually show that, come to a conclusion with those care gaps, help eliminate them, and at the same time improve the analytics themselves. So thank you again for having me on board.
Yeah, terrific, and I appreciate you joining us, Neil. And then lastly, to round out our panel is Andrew Mayhew. He has experience in accounting, software, and e-commerce, and believes that data-driven decisions are the quickest way to improving processes and workflows in any industry. And by analyzing data, he helps healthcare leaders reduce patient cycle times in the clinic setting here at Sync Times. Andrew, if you just wouldn't mind sharing a little bit more about yourself, and thanks for joining us.
Yeah, definitely. Thank you, Nick. Like Nick said, I'm the Director of Client Success here at Sync Times, and I've been in this position for about a little over a year now. And my background, as we discussed earlier, is in data analytics and e-commerce. And so that led to a great opportunity to join the team here at SyncTimes in order to use that information and that experience to help create a more patient-centered and focused visit for health centers across the country to overall improve patient satisfaction and experiences. So thank you.
That's terrific. Thank you, Andrew. Well, let's go ahead and get started and set the stage for our discussion today. George Deely of Dimensional Insights states that in healthcare, the phrase data-driven decision-making is a popular one, meant to describe how organizations integrate objective information to inform and improve all sorts of decisions. However, it's an admittedly abstract concept. Our audience today is a mix of clinical and administrative personnel representing federally qualified and rural health centers, as well as a few hospital systems. To help frame our conversation, Patrick, would you provide us with kind of an explanation of what data-driven decision-making means to you as an experienced healthcare administrator?
Yeah, I think we often, focus on the quality of the data when we're talking about data-driven decision-making. But we found the real opportunity is to pay attention to the quality of the decisions, and then to help those decision makers to be able to leverage the information that's available to them. So a lot of organizations get really focused on quality data, and the reality is they have a lot of quality data, but they haven't figured out how to successfully leverage that to create quality decisions. And so that's where our focus is. The way we approach that is we really look to make sure that the information, that quality data is being organized around the decision maker, that it's more position-centric. And so we use a balanced scorecard approach for that. And a lot of what we're trying to do is to help decision makers manage the unintended consequences of their decisions. So if you put a lot of good quality data in front of somebody, they've got to sort out which of those things really matter and what they expect from it, and how they're going to know if they're wrong, how they'll fail fast. And so the balanced scorecard approach helps to do that, to keep an eye on and to manage those unintended consequences. Examples would include, if you increase the new patients into a provider's panel, then usually that's with the intent of growing that provider's practice and productivity. But it's not uncommon to find that provider's productivity actually declines after they receive an influx of new patients. That can happen if their panel's already full and they're having a hard time keeping current on all the needs of their assigned patients. And so then their schedule starts to fill up further into the future. Their no-show rate goes up, and 6 months later, everybody's scratching their head wondering, how is it that we grew this provider's practice and they're actually now seeing less patients than they were before? Another example we've seen that's common is when a practice really starts to tackle the patient experience, they usually are quickly drawn to the dissatisfaction that the patients have with the amount of time that they feel they waste inside the healthcare facility. And they're often drawn to the first piece of good data that they have, which tells them how long the patient waits in the wait time, and they attack that. And they're usually successful in reducing that, but then they might be surprised if they find that the patient's satisfaction is lower after they reduce the amount of time they spend in the waiting room. And it's only after you really dig into that you find the unintended consequence here was that time wasted by the patient just moved from the waiting room into the exam room. The practice got more efficient at moving the patient out of a spacious, comfortable waiting room and shifted that wait time into the exam room. And the patients are actually less satisfied because now they felt that they were isolated, abandoned, and wondered if they hadn't been lost. And so 10 minutes alone in an exam room can feel like 20 minutes in a waiting room. And so what we do with balanced scorecards is we work around those decision makers and the decisions they're making, and we try to come up with the good data that's going to be relevant, not just to seeing if their interventions get their intended outcome, but to also make sure that they don't have any unintended consequences that set them back.
Terrific. Appreciate that, Patrick. I think that does a good job of, exactly, what I had hoped and really framing our conversation today. And right now I'm sharing with everybody some infographics that I think really do a lot. Neil, especially when I think about your work, these two graphics make clear how important the application of data analytics and artificial intelligence are in healthcare. Your company is at the leading edge of leveraging data with the use of artificial intelligence to maximize patient engagement and outcomes. Would you mind sharing with our audience examples of gaps in care that you've identified, and also how patient outcomes are improved through use of this data?
Sure. So one of the areas we're really focused on is how can we take some of the burden and overhead that physicians have that are unnecessary and offload that either to their existing care staff or to our services in a way that enables them to spend more time doing what they are capable and enable them to practice at the top of their license. So I'll give you an example. Is one of our care gaps that we recently identified was a patient had a medication, an ARB, that was found in the notes but wasn't in the medication section. So something that would normally take a significant amount of EHR review time and require going into the notes, our system can identify that and bring that to a care navigator's attention so that they can identify that this ARB has both actually been recalled, so our system knows that there was recently an FDA recall for this ARB, and as well as that this was causing a side effect that the patient was having. And now the care navigator can escalate that appropriately to the right person in the care team, so that one, this can prevent that patient from not adhering to their medication, but also having a worse side effect or outcome due to the FDA recall. Another example is a patient who was diagnosed with diabetes, but in notes we identified that the patient was having a problem with their injection site. So our system was able to identify that this patient had an additional layer of adverse effect from that condition, that the patient was actually type 1 diabetes. It wasn't specified in the problem list, and that there was a specialist involved, and that was the reason why it wasn't in the structured problem or medication list. In that case, our care coordinator could then identify who the specialist was and then address that issue appropriately. And again, address the administrative burden of the care coordination and the calling, while leaving escalating clinical decision-making to the appropriate care staff and provider.
Terrific, terrific. Thank you, Neil. Back to you, Patrick. I wanted to ask you, we previously talked about with your 20 years of experience in healthcare administration. I was curious, I'm sure that in that time, maybe more so in as you began, you had to make a lot of decisions that were based on a hunch or, just kind of a gut feel because there wasn't a lot of hard data to support it. With more data and even artificial intelligence playing a role in how patients are being cared for, would you be able to tell us about those experiences and how different healthcare is today compared to when you began?
So we're assuming that we don't still make decisions based on hunches then?
We're just hoping that there's a few less of those.
Yeah. Well, I guess what's changed, is the abundance of data and the ever kind of improving quality of that data to the point that I think today, the skilled decision makers, I want to be careful not to say leaders, because in healthcare, the decision makers are pretty much everybody. You're relying on a care team in our day that are making decisions independently, that they're empowered to be able to decide from the front desk to the schedulers to the clinicians to the operation managers and the nurses. Effective healthcare entities have to have decision makers throughout the entire continuum. They've got to be able to deal with a scheduling issue without asking for somebody else to make the call. And so that's pushed us to have more and more abundance of good data. But the skilled decision makers, I would say, in today's environment, and some of us probably feel like we're doing this based on a hunch, but it's actually a skill. Know what to ignore as well as what to pay attention to. And that's, I think, becoming a real skill is to be able to look through all of this kind of abundance of information and pull out the 2 or 3 things that really matter and understand the way they interact well enough to know if I do this here, it's going to have this short-term and long-term consequence, whether you're dealing with patient outcomes, whether you're dealing with the financial implications of your organization, your operational efficiency, all of those things. Your skilled decision makers today, that whether they think they're making it on a hunch or not, they're good at knowing what information to really pay attention to and what to ignore.
Sure. That's great. And Andrew and Neil, I'll offer the same question to you as, in your experience. What does adoption look like as far as relying on data? And, how eager are those in the healthcare industry, those that you're working with, to find data and find access to that data to be able to make those decisions?
Yeah, I'll add something in there. With my position, it's kind of interesting. You typically think of those using reporting and data analytics being someone closer to the C-suite or the executives that are somewhere in a boardroom looking at some data and making some decisions that affect everybody. However, I typically work more on the ground level with department heads, so that's nurse managers, clinical managers, and then even directly with providers and medical directors to analyze data and reporting for specifically their department, their patients. And it's I'd say it's actually been surprising how strong the adoption is to start using data and reporting to make changes at the operations level, from the workflows, the clinical workflows that are being used every day, just how much, doctors and nurses and nurse managers rely on reporting that we help to provide to make changes to the everyday workflows that ultimately improve the patient experience and satisfaction.
Sure, great. And I don't know if you wouldn't mind, Andrew, if you just kind of expand upon that as far as how they are relying a little more specifically to improve the patient experience, from the time when they're entering the clinic specifically, maybe not so much, maybe in Neil focusing a little bit more on analyzing, the patient's data, but more or less what that experience looks like for the patient when they're visiting the doctor.
Yeah, definitely. So, kind of what I've noticed here is that sort of what Patrick was saying is we're eliminating the need to make decisions off of hunches, and we are using data to either confirm or disprove ideas that we may already have. So that's I think that's one of the key principles of data-driven decision making is we're not necessarily using this data or this report to suddenly, give you an epiphany or tell you what you need to do to improve operations at your health center. But instead, you already have, decisions or ideas that you potentially want to enact, depending, any level of the operations, whether that's, trying to move patients through the exam room quicker or through the wait room, or if that's encouraging, nurses to spend more time collecting more medical history, so on and so forth. There's lots of ideas that we have out there that we think that will help, that we already have, and we're just waiting for something that helps to prove or give validity to that idea. And I think that's what data-driven decision making is all about, is having these ideas and then using data to tell us, yes, go ahead and go forward with that, or on the flip side, to help us stop from making a bad decision. Kind of like the example that Patrick gave earlier of let's move patients through the wait room quicker, and then only to have patient satisfaction scores decrease later on. And so I think that's kind of the key principle that we try to keep in mind as we're working with anybody to analyze data and make improvements from that.
Okay, terrific, thank you. And I want to ask you, the healthcare industry really is moving towards a more data-driven and patient-centered model, but it seems as if there is still room to grow. In your opinion, where do we go from here? What else do you see being analyzed to be able to provide for greater outcomes and a better patient experience for the patient?
Sure. I think, as Patrick said, there's a tremendous amount of data and high-quality data that's already in the patient records and the billing history. I think the challenge is that it's not easy to access, and it's very difficult to actually build relevance. It's almost like the existing systems make it difficult to find the relevant insights. So, for example, for a given chronic condition, whether it be diabetes or congestive heart failure, there's insights that are across all the different silos of the EHR, and that makes it difficult to penetrate for a care team. If you can identify the relevant items or insights across those silos, it enables the clinicians to make better decisions. The challenge just becomes from operationalizing this. Providers are already have a tremendous amount of overhead and very little time. And the key and the challenge is really to enable those insights to be appropriate at the right time, at the right place within the workflow, so they're accessible through anyone who's providing care for that patient. What we see going forward, and some of the things that we've been working on, is when you have a good, really strong understanding of the patient's chronic conditions from the data side, you can power programs such as care management, chronic care management, but you can also improve HCC scores for patients that are at risk, and you can also help start to build out clinical trial recruitment once you, in a much more effective manner, once you have this greater context around patient conditions. So we see that there's just, again, a tremendous amount of potential just with the existing data, and really it's about how you can use that to improve the patient engagement and really the relationship between the patient and the physician. And that's why it's actually been very interesting to see some of the things that ThinkTimes has been able to do in that regard.
Terrific. Andrew or Patrick, anything you'd care to add as far as where you see, what the future is of healthcare, and as we move towards that more data-driven and patient-centered model?
Yeah, I guess I would, it's interesting because when I think about what Neil's talking about and where those opportunities are, and then, if I look back 20 years, I think kind of the evolutions we've gone through are sort of like peeling back the layers of the onion, or different analogies you hear like that, where for the first decade of my career, data was being concentrated at the executive level. We were getting good at figuring out what do senior leaders need to make better decisions. And then for the second decade of my career, the focus was site managers. So, we kind of evolved from where senior leadership had good information, knew how to use it, knew how to make better decisions because of it. Now we needed that to really move down to site managers. So from kind of a longer term perspective with executives looking out months, to site managers, which is shorter term, more being more nimble, looking out weeks. Now where we're at is we're really looking to bring better data to inform better decisions at the point of contact, the patient care. What's happening today? What's happening right now? And that's really there's really two spaces for that. One of them I hear Neil speaking to, and that's improving the provider's decision making. So what is all of the, not just everything that's captured in the chart, but the total picture for the patient and what their needs are. And so improving the medical decision making of patient care. And then what I think I heard Andrew speaking to is surrounding that, what's going on with the practice today. I'm trying to help providers, my experience is in the outpatient world, so trying to help providers avoid the natural daily trap of being so immersed in the patient in front of them right now, the care that that patient needs, and being so detached from any good information that helps them to understand what's happening in their practice right now. How many patients are waiting? Where do you need your MA to go, and how do you communicate to your support team what you need from them? And being able to have situational awareness in the middle of a busy day. I think that's really where we're headed now. And those decision makers, they need more real time, more point of care decisions to be effective. And that's gonna determine which entities are really successful, I would say, in the next decade.
Terrific. And you just mentioned something there, situational awareness, and I think that's a good transition. I'll ask Andrew to dive in a little bit and talk about how data is being applied in the clinical setting to provide for a better patient experience. And that's something that really with the flow stations that the SinkTimes solution provides for is, in real time, that situational awareness that anyone at any time can see where a particular provider is or what, to be able to see the care plan in real time as the providers entering that into the EMR, that they can communicate that to the rest of the care team, and they know in real time what needs to take place. And it's really removing that barrier that closed door creates within the clinic. So, Andrew, I'd actually want to ask of you, if you wouldn't mind, if you could share a little bit about how data is being applied in the clinical setting to provide for a better patient experience and provide the audience with a look into the data that's being collected and analyzed to be able to provide for a better patient flow.
Yeah, definitely. So let me go ahead and just, would that be all right if I shared my screen at this time, Nick?
Yeah, if you wouldn't mind, if you want to go ahead and grab that, that'd be terrific.
Just to start off, I'd say there's two key metrics that are being used in at the health center level of what we need to be looking at the data in order to make improvements in the patient's day-to-day experience. So let me go ahead and share my screen here and move over to our data set here. So the first key data set that I think is important for us to be looking at as healthcare administrators and decision makers, and that is the cycle times around what the patient is experiencing in the health center. And I say cycle times because I think there's a little bit more to it than just wait times, and that is we have time with a provider, we have time with a member of the clinical staff, so that could be a clinical assistant or a nurse, and then there's the time alone. So that's actually what we're looking at here on the right-hand side of my screen with these colorful bar graphs here. We have it broken up into 3 different sections here. So that red color there is an example of alone time that a patient is experiencing in the exam room. That green section there is time with a member of the clinical team. And then blue is time with a care provider. You'll notice that we're really focusing here on the time spent in the exam room. And that takes us back to what we talked about earlier of really targeting the areas where the choke point exists, and in a clinical setting, that's in the exam room, right? There's not much we can do in the wait room to improve the efficiency of the visit once the patient gets back to the exam room, and that's all reliant on the providers and the nurses and the medical assistants being able to communicate effectively in order to provide quality care for the patient. So what I typically do, I mentioned earlier, I typically work with nurse managers, medical directors, in order to help them analyze their cycle time information at their health center. So what this is here is this is our demo data set, and it just includes about data from about 5 different departments over a few different organizations that we work with. So down here we can see if we wanted to dive into a specific organization. Let's cite 23 here, a little bit generic, but what we're seeing here is, when we started with this department, we were seeing, fairly long cycle times. So if I hover over that, we can see that cycle times were up around 50 minutes, with a good portion of that being time that patients spent alone. So we're seeing here that less than 50% of that patient's visit in the exam room was with a care provider or a member of the clinical staff, which, if you think about it, as a patient is pretty bad. To give an example, I actually had a medical appointment just recently where it started out great. I was in the wait room for just a couple minutes, in the exam room for just a couple minutes, waiting for the provider. And then the provider came in and spent, I think, less than 2 minutes with me, which from a patient's perspective, they just spent, or from my perspective, I just spent 30% or less of my time with a member of the care team, these people that I came to see to receive healthcare. And so even though, they were, I had a great experience while I was with them, you start to feel a little bit abandoned or left out when there's a very slim amount of the time that you're there is actually spent with a member of the care team. And so that's why we always try to focus on decreasing patient alone time without sacrificing time that a patient spends with a member of the care staff, and that's especially the provider. And so these are the type of reports that help us to see and drill down at a specific department or drill down to a specific provider to see where the improvements can be made. And this really opens up the door for discussions to be made on what can we do to make the process more efficient. But I think we have to be careful with data. I think there's a lot of organizations that have a lot of data, a lot of quality data, but it never gets to see the light of day. And so what we've seen, so here we have a great example. So here we started and we see this drastic improvement in cycle times, right? From 28 minutes of being alone down to 16, 17 minutes of alone time. And then we see it kind of shoot back up pretty rapidly. And so here we were looking at this data and we're like, man, I wonder what's happening here that's causing this increase to go back after we had so much hard work to improve the patient experience to here. And what we found out was this location got a new nurse manager, and the new nurse manager wasn't as familiar with these reportings and didn't know it was part of their weekly department meetings to share this information with their providers and with their clinical staff. And so what we need to be aware of is, even though we have this great data, it doesn't help us if we don't use it. And so that's what we've seen with many of our health centers, is those that are making great improvements in patient experiences and increasing patient satisfaction are those that are sharing that reporting with their providers, with their clinical staff. A lot of health centers out there, I think they're a little bit scared to get into these specifics with their clinical staff for many different reasons. But overall, what we've seen is the more that an organization is transparent with their goals, transparent with their reporting and their metrics that they're tracking, the more success they're going to have in improving the patient experience. And I think in the end, the people who come into healthcare come to help people and to help the patient. And so as we improve the patient experience and patient satisfactions, we also work to improve staff satisfaction as well. So this is kind of a quick snapshot of what we do to provide reporting for the patient experience, for nurse managers, for ops managers, for pretty much everybody in the organization in order to improve that. And then I might just jump in really quick to another report here. So
actually, Andrew,
go ahead.
Just ask a quick question. So you mentioned patient satisfaction. I was curious, and it was something I believe Patrick had also mentioned earlier, getting that feedback from the patients. Can you share a little bit about how clinics and health centers are going about collecting that information from their patients, and also how, if there's a correlation between, we saw just a second ago how there were some drops and then maybe it shot back up and then they were able to get those cycle times, under control. how, if there is a correlation to patient satisfaction. I'm sure there is with those cycle
Yeah.
times.
Yeah, definitely. So I touched on one, which was set of data, which was cycle times, and then another set of data that's really important to track at the health center level is patient responses direct from patients through patient surveys, which is why we've started placing patient surveys in the exam room so that we can collect that information from patients while they're at the health center when that information is most relevant, where we're most likely to get first of all, when we're most likely to get responses, and second of all, when those responses are fresh on the patient's mind. And so that I'll just kind of jump over here briefly. So what we're seeing here is an example of a SyncTimes tablet that you'd see inside of a health center. And what happens when there's a patient in the room, like we're seeing here, what happens is if there's nobody in the room from the clinical staff, is we get this this pretty simple survey here. Is how is your visit going so far today? And the patient's able to interact with this, and as they click on one of these responses, it alerts everybody in the care team what that patient just said. So it gives real-time data to the care team in order to address those patient concerns before that patient ever leaves the health center. To improve that experience for the patient, and also to avoid that patient going out and perhaps leaving a poor review on a review board somewhere for something that could have been pretty simple. The provider had an emergency in another exam room, and that patient just didn't know about it, and so they felt like they were forgotten. So as they click on a response, and then you can kind of see on the flow station, okay, the patient in exam room 4 is very happy with their visit. We can go in and say, hey, we're glad that you're having a good experience today. And we hope that to see you again soon. And then also, on top of that, we have this same, live reporting for the care team to see as they're going about their daily operations to add to their situational awareness of what's happening in the clinic that day, how many patients they have waiting, and how they're doing on patient wait times and so forth.
Terrific, Andrew. I'm sorry, I just you had hit on that, and wanted to ask that question. I think you were going to show some other reporting, maybe around. I don't know quite where you were going. Maybe a utilization.
Yeah. I was going to kind of sidestep over here into a different report that we have that actually touches on a completely separate area of the patient. It's not so much the patient experience, but of health center operations. So what we have here is what we call the provider scheduling report. And what this report does is it enables operations managers, front desk supervisors, to manage provider schedules without the guessing work. So a lot of times what I hear from providers when I'm at a health center is that they're getting double booked, triple booked, quadruple booked, at a certain hour that's, just the worst thing that could possibly happen. And so what we've created was a report that helps us to analyze, what a typical provider schedule looks like on the day-to-day basis. And this incorporates, there's a lot of underlying variables such as no-show rates, provider admin time, so on and so forth that affects the schedule. But what we're able to see here, let me just go through a quick example here. So we'll say we want to analyze site number 22, and we'll go, let's just kind of go through this quickly here. All right, so here we have pulled up a specific provider at a specific health center, and let's go ahead and look at their schedules. So what we're seeing here, and let's make it for the last few months here, so that we get a good idea of what this provider schedule looks like. So what we're seeing here is that this provider on Thursdays So right now we're looking at a heat map where green means busy and red means slow. So obviously during the lunch hour at 12 o'clock, there's not a lot of patients seen. But what we're seeing here is 8 o'clock is the busiest hour, or 9 o'clock is the busiest hour, where this provider has seen 39 patients over the last 4 months. But what we're seeing here is the 11 o'clock hour, it decreases to 10. The 2 o'clock hour, it's at 19. 4 o'clock, it's at 22. And so what this report is used for is to be able to find those areas in a provider schedule that have the capacity for additional patient slots in order to increase access for patients in this community. And what we've actually seen worked well with this is when clinic managers work hand in hand with providers analyzing this report in order to find those areas in the schedule where a specific provider can handle more visits. So that way it's not a guessing game. It's not admin enforcing rules upon providers that create for poor provider satisfaction, but it's cooperatively working together to create a better patient experience, and also to increase access for more patients to have a quality care experience. So that's I guess a brief example of some reporting that can be used in a clinic setting to improve patient care and experience.
Terrific. Thank you, Andrew. And the thing I was curious about, as we've gone through this, I'd ask this of you, Patrick, and Neil, that feedback from the patient. It is so important because, it certainly gives you a kind of a red flag if you have a dissatisfied patient because they may be going somewhere else. And, we're doing all this work, we're collecting this data to be able to have a healthier patient, but we want a happy patient at the same time. And I was curious, Neil, perhaps with your with some of the patient navigators, if there is any type of solicitation of feedback from the patients, or maybe that you're just hearing from the health center, are they doing any type of surveying of their patients, and perhaps with what your work and your care for those patients, how that's impacted their overall experience at their health center, at their doctor's office?
Sure. So that's a great question. One of the things that we look at is, while there's obviously a lot of valuable information in the EHR, there's a tremendous amount of upstream information, additional information that's not in the patient record that can be valuable, especially around patient satisfaction, sentiments, other issues. And so one of the things that we do is we have an opportunity in that care management interaction to capture some of that information. What are some of the preferences the patient has? What are some of the things that they wish they had access to? And really that comes down to that building that report and capturing that additional information, summarizing it, and then being able to send it back into the EHR in a way that the physician has a summary of this additional information, whether it's medications and problems that were identified that are not in the EHR, whether there's preferred communications, whether there's aspects around their life in terms of, do they have a relative, do they have other people living with them, do they have challenges accessing transportation. Again, these are all fairly simple insights, but it's just a challenge. Either they're not in the EHR or they're difficult to find there. And that's one of the things that we look at capturing and augmenting the care team's insights.
Terrific. And Patrick, do you have any experience maybe surveying that you implemented, or just with the health centers that you've worked with, and how they are soliciting that type of feedback from the patients?
Yeah, I guess in terms of how you can get it, it's like everything else now. There's a variety, and organizations can choose what the best way for them is. Health centers tend to focus on phone surveys because you can conduct them in a multilingual environment, and you're not going to lose the feedback from low literacy patients. And so phone calls, they also provide an opportunity to to kind of probe, if there's a low ranking, then to get some verbatim responses about why. But then I think more looking for ways to transition that to real time without losing some of those benefits. So I think the ways you get it are evolving, and I think there's good options, and there's lots of different solutions, all of which can work. How you use that data then I think becomes the perhaps more interesting conversation. Patient experience, patient satisfaction is highly correlated with patient outcomes. And I think that healthcare is still having a hard time digesting that, valuing that, recognizing that, even if you properly diagnose a patient, even if you provide for them the precise, perfect treatment plan, even the right prescription, if they had a terrible experience in the process, the likelihood that they're going to benefit from that treatment plan, that prescription, is severely diminished. And so finding ways to not just make sure that the clinical information is available to improve the medical decision making, but that it's provided in a context where the patient feels like these folks care about my time, they care about me. I don't feel like I've been kind of processed like a widget. I feel like I've been actually cared for in my healthcare experience. I think that's something that data can help with if we value that data. I see as we work on providing information to decision makers, this tends to still be the piece of data that encounters the greatest resistance, that clinicians and other decision makers are quick to push back and question the validity. What's your sample size? And I think these are some opportunities to say, look, this does matter. Patient outcomes are highly correlated to the patient satisfaction and experience, and let's get that into the perspective and find creative ways to know how they're feeling at the same time that we're dealing with their conditions and the appropriate treatment.
Terrific. Thank you, Patrick. And actually, just had a question come in, and actually we're just about the right time. So if anybody does have questions, feel free to submit them through the chat feature. And the question, I think, is Andrew. We had somebody ask about how you were tracking those cycle times. Would you mind just explaining a little bit how that is being captured within the clinic for each patient?
Yeah, definitely. Let me go ahead and share my screen one more time in order to demonstrate that. So going back here, all of the data entry is happening at the clinic level. And so that means, and it's incorporated in their workflows. And so when a patient is entered into an exam room, this touchscreen tablet here is tapped here, and that enters the patient. And then we have these timers that start immediately, the total time and the time that the patient is currently experiencing. So that begins immediately, and it starts tracking that cycle time information and storing it in a database that we can then create reports off of. And so anytime someone enters a room, they badge in using their RFID cards that they typically already are using, and that'll place their picture here, and so everybody can kind of see where they are. But that also allows us to see, how much time a patient has spent with a nurse, a specific nurse, how much time they spent with a specific provider, and how much time they've spent alone. And so that allows us to see, retroactively, what exactly a patient experienced during a visit, but also we can see, during the visit, what the patient is experiencing. So these numbers are obviously a little bit skewed as it's just a demo example, but we could see, the patient's been in, for a total time of this, and they've been waiting alone for the provider for this long. And so not only do we have the retro reporting, but live, we can see what exactly the patient's experiencing and take steps to improve their experience while they're in the health center. And that's also what we see here with this real-time reporting. We can see how we're doing that day, how we need to improve, and then we can start discussions, with our providers, with our nurses, with our nurse managers. Hey, why don't we try doing this to improve the patient experience, or maybe something else? And so that's how the data entry is happening, and how it's used on a day-to-day basis.
Andrew, another question for you. So what does adoption look like to be able to actually get the members of the care team to begin using the system?
Yeah, so utilization of the system definitely depends on one, what are the goals of the organization? So if the goal of an organization is patient-centered, and that culture is spread out throughout the entire organization and at the health center, then adoption is very easy, because we're willing to try new things, and we're willing to stretch ourselves in order to improve the patient experience. And what we've seen is 9 times out of 10, that's exactly what we have is nurses, medical assistants, providers who are frustrated with their current workflows, frustrated every time they have to run around the hallways looking for their nurse or looking for their medical assistant to help them in a procedure or in the exam room. And so what we're able to do is not only just perform the data entry, but we're also able to, add to and enhance workflows that are currently being used every day. And so it's kind of a win-win type of situation for health centers.
Okay, terrific. Thank you, Andrew. It looks like we haven't had any other questions come through. So actually, just with 5 minutes left, if there aren't any other questions, I'll go ahead and thank everybody for joining us. Like I said, this at the open, this is a part of a larger webinar series focused on the patient experience. So I'll encourage you to be on the lookout for future emails. We look to schedule these about once every 6 weeks, and where we are focusing on how we can better provide for a better experience and for greater outcomes with patients.